Hi everyone, and welcome to the Media Plus Health Symposium at Virginia Commonwealth University. And we'll just give a minute so everybody can join us, so please stay with us. Okay, hi everybody, good afternoon and welcome to the Media Plus Health Symposium at Virginia Commonwealth University. And this is third research panel under the topic Beyond Mobile and Social Media, Trends in Health Communication Research. And I'm Grace Park, an assistant professor at VCU, and she is Rowena, an assistant professor at VCU too, and she is one of our presenters here, so she's here next to me. And we have 4 presenters today. And let me introduce each of them. So first presenter is Marta, Fadda, and Peter Schulz in Università, della, Svizzera, Italiana. I hope I pronounced it right. And my second presenter is Rowena, Briones at VCU. And third presenter is Christal R.S at PCS. And our last presenter is Ernest Martin, Candace, Parrish, and Vivian at VCU. And we have a discussant, Dr. Yan Jin at the University of Georgia, and she will going to lead a discussion section for us. And let me briefly explain about our section today. So each of our presenters will have 8 to 10 minutes to present their study. And after all of the presentations, we're going to have time for questions and discussion. And if you'd like to see more information about presenters, please go to our website, Media Plus Health Symposium website, and you can see their bios. And of course, during the presentations, if you have any questions, please post your question on Twitter with the hashtag VCU Global Health. Or you can just try to follow the Twitter account of Media Plus Health Symposium account at VCU CMH. Well, then let's start our research panel with our first presenter. Marta, are you ready?
Yes, I am.
Yeah, please start your presentation.
Yes. Can you see that?
Yes.
Okay, does it work?
Yes.
Okay, great. So, hi everyone from Switzerland. My presentation would be about content analysis of Italian online forums, where parents discuss about their children's vaccinations. So you might have heard about the measles outbreak started in a Disneyland theme park in California last December, which has now spread to 70 people in 5 states. Of the infected people, health authorities found that no one was vaccinated against measles. And this topic of vaccination refusal is probably more relevant today than ever. And this news also leads us to think about the anti-vaccination movement again, and most importantly about the dynamics that lead parents to decide not to vaccinate their children. But while in the US, the resurgence of some diseases is to be blamed on pockets or clusters of unvaccinated people, and vaccination rates are generally stable, in some European countries, an increasing number of parents are deciding not to vaccinate their children. And this is resulting in a revival of diseases such as measles, pertussis, or meningitis. And we know that anti-vaccination information plays a major role in changing people's attitudes and beliefs about vaccinations. For instance, after a paper suggested a link between MMR and autism in 1998 in the UK, several parents have started to have increasing concerns about the safety of vaccinations. And there's also a kind of confusion about vaccination side effects right now, resulting in a spillover effect where more and more vaccinations are being questioned. We know that the Web 2.0 offers a huge potential for vaccination decision making. So the good thing for us is that it provides great access to data and cheap and efficient tools to identify areas for intervention. And for parents, it offers a special place for discussion since it allows users to tell stories, and these stories are often easy to understand, concrete, emotional, But at the same time, this is often exploited by the anti-vaccination movement, which, using personal narratives, delivers information that is easier to understand than the statistical data presented by health authorities. And also, we know that websites that allow or promote interaction among users are a source of health information that is growing in popularity. And since we know that as many as 72% of users will trust health information they obtain from the internet, it becomes essential to understand what is shared online. So we decided to conduct a study in neighboring Italy, where vaccination rates have decreased in the past 4 years, causing an increasing number of epidemics of vaccine-preventable diseases. So just to give you an example, Italy has experienced almost 2,000 cases of measles since December 2013, which is the highest rate registered in Europe by the European Centre for Disease Control and Prevention. And Italy is also facing a strong public debate after a court ruled out that the MMR vaccination had caused autism in a child and awarded his family $240,000. So our main scopes were to assess the characteristics of parental online exchanges on childhood vaccination, but also to monitor vaccine acceptance to get an idea of how many parents are against vaccines, which vaccines parents are most worried about, and so on. And from a more theoretical point of view, we were also interested in studying the dynamics through which information reaches parents and contributes to their decision-making regarding their kids' vaccination. So we would like to further explore the data within the two-step flow of communication theory, which postulates that information stemming from mass media first reaches opinion leaders, who in turn pass on what they read and hear to other people for whom they are influential. We opted for a content analytical approach, since content analysis is systematic and a quantitative method, and it also allows for a theory-driven approach. So we selected the first 3 discussion boards by Googling the words vaccination and forum in Italian, and we obtained permission for the 3 forums, from the 3 forums to collect the data for research purpose. We retrieved all threads, including the word vaccine in the title, and then we selected only those threads discussing childhood vaccination and with at least 10 posts. And we also set a starting point, which was the beginning of 2008, when social media usage increased in Italy, while our limit was the day we retrieved all threads. So this is the list of our measures. As you can see, we included both formal and content categories. So the data contain information on the post time of publication and on the gender of the author, for instance, but also up to 3 themes discussed, users' level of concern and need for information, and we also identified up to 3 vaccinations discussed, and for each one we could select up to 3 arguments and sources, plus the user's recommendation and attitude. We hired and trained 5 coders who were randomly assigned to a different set of threads without a prefixed coding order, and we computed Krippendorf's alpha 3 times. So first time during coders training, then in a pilot coding, and finally in the middle of the coding to assess intercoder reliability. Krippendorf's alpha was 1 for all format categories, while for content categories it ranged between 0.73 to 0.87. And this flowchart shows how our sample looks like after applying our inclusion criteria. So of the almost 5,000 threads retrieved, we discarded those which were off topic and contained less than 10 posts or were published before our threshold, for a total of 261 threads, which made about 5,300 posts. As you can see from this table, most users were female, and the mean number of posts published by each user was 19, with a standard deviation of 33. More than 1/3 of the sample expressed concern about vaccinations, while 14% contained a request of information, and almost half of the posts showed a negative or undecided attitude towards vaccinations. This chart shows the percentage of the main themes discussed. As you can see, people mainly discuss vaccination side effects, followed by vaccination schedule and efficacy, and only a small number discussed the risk of a disease, the link to anti-vaccination page, or doctors or pharmaceutical companies' interests. People also mainly discuss vaccinations in general, which is in line with what I mentioned at the beginning of my presentation. That is, that parents are extending their concerns over all vaccinations. The second most discussed vaccination is the one against diphtheria, tetanus, and pertussis, while the third most discussed is the measles, mumps, and rubella vaccination. So this is in line also with children vaccination schedule in Italy, with the last vaccination being also the non-mandatory ones. To operationalize the opinion leaders within the discussions, we chose a number of features. So we decided that they need to have published several posts, but they also need to show some kind of stubbornness. So we would look for those who have a stable attitude over time and either concerns about vaccinating or the failure or refusal to vaccinate. They should not need information, since they are supposed to be those who provide information by sharing links to external websites, for instance, and they have to make attempts to convince other people to vaccinate or not to vaccinate by offering explicit recommendations. And since only 14% of all users have published only one post, and as many as 7% more than 10, we will try to identify who the opinion leaders are and who are those that might be influenced by them. And finally, to operationalize the influence of the opinion leaders, we will track the opinion change occurred after being exposed to their post within the same thread. So a positive change will be the shift from being undecided or against to in favor of the type of vaccination discussed, while a negative change will be from undecided or in favor to against, or from in favor to undecided. And so far we tracked 302 changes in authors' attitude, of which the majority were negative. In conclusion, this study reinforces the importance of studying the internet environment and its potential for parental vaccination decision making. And although there are a number of ethical issues about it, the inclusion of immunization experts within online discussions among parents needs to be considered, so that every time someone is exposed to the wrong information or simply asks a question, a medical professional is there to provide the right answers. Medical professionals should also be aware of what is shared online so that they can vaccinate parents before they are exposed to that information, or simply be prepared to counter-argue against it. And I can see further development of these studies, such as creating a tool that allows us to constantly monitor vaccine acceptance. But what I think would be also very useful is a deeper study of the communication strategy adopted by anti-vaccination campaigners, so that health authorities can eventually employ them to increase vaccination acceptance. Thank you very much for your attention.
Thank you so much for your hard work and presentation. We enjoyed your presentation. Then let's move on to our second topic, Will You GYT? Discussions with young adults about GYT, Get Yourself Tested campaign done by Rowena Briones here. And she's ready to present her work.
Great. So I guess I'm a glutton for punishment, as those of you who have been with us all day have seen a lot of me. But let's see. It'll be really embarrassing if I can't get this to work. But let's see if this. Yeah. Yeah. Great. Okay. Okay, so I don't know what first. Okay, yeah. Okay. All right, great. So I'm really excited to not just be here in the capacity as an affiliate faculty member of the center, but also to share my research with you. Just want to give a shout out to my mentors over at the University of Maryland, as I worked on this project as part of my dissertation research. So kind of to jump right in terms of the problem, according to the CDC, young adults all aged 15 to 24 years old account for 50% of the 20 million new sexually transmitted infections in the U.S., in spite of representing only 27% of the sexually active population. So with that said, there's definitely a need in terms of trying to get sexual health information out to young adults and kind of harnessing them with the tools that they need to make healthier decisions when it comes to sexual health. So a part of the possible solution is to utilize online tools and the internet. As Pew has told us, when it comes to college students and undergrads, 98% of them use the internet, but only 17% use it to look for health information on sensitive topics, which can include sexual health. So the purpose of the study was that I evaluated a campaign called the GYT Get Yourself Tested campaign. And as part of this, I worked with the CDC Division of STD Prevention and gave them some feedback on how they can better utilize the online space to help improve and inform folks on the campaign materials. So for those of you that are unfamiliar with what GYT is about, it was developed in April 2009 as this movement called It's Your Sex Life. It was a partnership between MTV and the Kaiser Family Foundation, along with the CDC and Planned Parenthood. The main goal and mission of this campaign is to reduce the spread of STDs among young people through public information channels. And with that, online was definitely a part of that. And in terms of some of their initial successes when the campaign first came out, in the first month, there was a 25% increase in testing, STD testing, at Planned Parenthood clinics nationwide. And the GYT website saw more than 270,000 unique visitors. So in terms of the method, I conducted 50 in-depth interviews and 5 focus groups to get their insights on this campaign. These participants gotten through a participant pool through the University of Maryland data collection pool, and also through my personal connections, reached out to folks who gave me access to students that could be interested in participating. As you see, this was a qualitative study, so data was analyzed using a grounded theory approach, using constant comparative methods to gather themes across the data. For the purposes of this, I'm not going to report on everything, but just kind of touch on some of the key results that I presented to the CDC, and these came in 3 categories. The first was some recommendations and insights in terms of the campaign in general. Secondly, some actions surrounding the campaign, some calls to actions that the campaign had. And then third, just more general suggestions for improvement. So in terms of the GYT campaign, there was some confusion regarding the target audience. As you can see from the background of this slide, they used a lot of bright colors, some cartoon type images, so participants were a little confused as to who they were really targeting, because according to the campaign developers, they were really reaching that young adult college age demographic. So as you see from this quote here, they thought maybe it was for high school, a younger crowd, etc. However, they did feel that the campaign materials had the ability to motivate these young folks to get tested. They thought that it was empowering, it kind of moved people to not feel embarrassed or ashamed. So that was great in that sense. They talked about also, in terms of actions surrounding this campaign, how they would go about sharing this campaign with their peers and those who might need it. As the participant said, and as you see from this quote, it was more of a passive sort of sharing of information, such as, through casual word of mouth or informal methods, or if, for instance, a friend came up to them and had questions concerning this type of issue on testing and STDs and sexual health, it wasn't so much on social media channels unless it was something relevant. And in line with that, there was definitely discussions in terms of how folks can feel a little embarrassed surrounding sharing this information. As you can see from this focus group exchange, participants felt that, it's pretty taboo topic, and that if they post something like GYT on their personal social media page, that folks would think that they, might have some sort of problem or issue in terms of sexual health, and they don't kind of want to be associated with that, as it's as we've learned today, that it can be a very stigmatized, taboo topic. In terms of suggestions for improving this campaign, there was conversations in terms of who the ideal GYT spokesperson could be. Conversations came surrounding using celebrities as a way to get the message out there. I guess this is pretty dated, as you can see, because Justin Bieber was mentioned as, I know he's coming around now, so maybe he'll emerge again, but folks like Justin Bieber are those that could serve as role models for this young adult audience in terms of having a voice and getting the message out there on how these young adults can be healthier, and kind of who can serve as that celebrity spokesperson for the campaign. In addition, when it comes to appeals, the participants said that they want something realistic. As this quote says, they don't want to be talked down. It should be a frank conversation. When the idea of fear appeals came to them, they were very against using a fear appeal. They don't want to be scared with pictures or whatnot to do what's right, but kind of just a very frank, open, transparent conversation that we should, that young adults should know this information and that it can help them, build for their future. Also, other than the celebrity spokesperson, a lot of folks that were interviewed talked about how they would like to hear from their own peers, kind of personal stories coming from someone like them, someone that's like them, that personal relevancy piece, that have a story to tell and are able to get the message out there to kind of help drive that home, that, yeah, there are folks out there your age that kind of dealt with issues related to STDs, STIs, and testing, and so kind of motivating young adults to move toward that. And then finally, some just general tactics that were mentioned by participants on campus events. Someone mentioned maybe some sort of benefit concert that could be campus-wide, smaller type of events such as tabling in common areas or having speakers come to classes. When it comes to the actual tools, having more interactivity, more engagement on web content. Someone recommended having more video content to be able to drive the message home. And then there was really interesting conversations that I had with participants about the state of sexual education in the United States and how we really need to start having these open conversations surrounding sexual health and what we do. And as much as, and this is a media symposium, as much as media has really, there's a lot of sexualized media out there, it's still interesting how the United States is still pretty, we're still quiet about, being open and transparent about sexual health and really giving the education that young people need, especially when they move on to college. So, in conclusion, I gave this report to CDC and telling, that they had aspects of the campaign and their online channels that were very useful in getting information out there in terms of motivating young adults to get tested and to drive the call to action that the campaign has. But, based on these recommendations, there definitely is room for improvement. And I'm happy to say that after I presented this to them, they definitely appreciated the feedback, and we're in the process of developing a GYT part for high school students, so we're definitely taking that insight on how they can move forward from that. So that's it for me, and I thank you and look forward to your questions.
So thank you so much for your hard work. It was really interesting study. And our third presenter is Christal Johnson at PCS, and her research is about the virtual vernacular of health, understanding how Black women interpret obesity and weight loss messages. Christal, it's all yours. Are you ready?
Yes. Can you hear me okay?
Yeah.
All right. Perfect. Can you see my document yet?
Not yet.
Okay, sorry about that. Give me a minute. Thought I had it uploaded.
do you need any help to open your PowerPoint slide? Then Marcus is here.
Yeah, I'm looking for it.
Christal, you go to the left in the Google Hangout window to the green button with the arrow.
Okay.
You click on that, and you should be able to see your PowerPoint slide in there.
Okay. Let me see.
You click on that. So on the left, the green arrow in Google Hangout. And,
Okay.
And then there should be various windows opening up for you, and you should be able to see your PowerPoint slide.
Ah, there it is. I just went to the green arrow.
And now if you could, we just saw it, it went away again.
Okay, I just selected it. Can you see it?
We can see it now. And
Okay.
now, if you could move to the second slide right quick, so we can see that it's.
All right.
Well, we don't see you moving the slide.
It's still not moving. Okay. I'm pressing the down arrow. Is that right? To move through the slide?
Yes, you should be able to. But are you seeing it move on your computer?
I'm sorry. Am I seeing what again?
Are you getting to your second slide on your computer?
No, it's not moving. I'm moving the arrow, but it.
Christal, use the right arrow, not the down arrow.
Use the what again?
The right arrow. The right arrow.
On your keyboard.
Not the down arrow.
Yeah. I'm using the right arrow. It's not going anywhere. Is there anything on the left I can use?
So let's do this. Click on Stop Sharing.
I'm sorry. Can you repeat that for me?
Can you click on Stop Sharing the slide? There's
Okay.
a button in your screen that says Stop Sharing.
Okay. It says stop. Okay.
Okay. So now I want you to go to your PowerPoint, to the actual PowerPoint program.
Okay.
And then go to slideshow and press from the beginning so that you really start the slideshow for your full screen.
From beginning. Okay.
So now you should be seeing nothing but your PowerPoint, right?
Correct.
And then on your keyboard, press Alt, ALT, and Tab. And then press the Tab a couple times until you see a green speech bubble, Google Hangout. And then let the keys go once you have that selected.
So Alt Tab.
Yeah, and then just keep pressing Tab, and you will see how you will be able to choose different programs. And there's a green, kind of like a talk bubble. You see that? Where you can select Google Hangout?
Tab and Alt. No, not.
You gotta keep Alt pressed. So press Alt and Tab, and then keep Alt pressed, and then click on Tab, and you can select different programs.
Okay, it's just showing me. Oh, I see it. Okay.
And then you select the green bubble for Google Hangout. Okay, then you're back in Google Hangout, and now you're going and you click on the left. You click on the green arrow, the green box with the white arrow.
Okay, is it coming up?
And then you need to select the PowerPoint that has the full screen. So where you see your beginning slide, only the beginning slide with nothing around it. And then you should be able to share it.
Okay, I just did that. Resume slideshow. Coming up yet?
Yeah.
Oh, I do apologize.
Something is coming, yes. now let's see. I think you might have not selected the right one. See if there, go to the green arrow again and see if there's a different one that you can share that only has your first slide, not with the program around it.
Okay. Green arrow. So are you want to go back to the actual slide? Is that what you're saying?
No. Stay in Google Hangout. Stop sharing. You're sharing. I think you're sharing the wrong one. Stop sharing.
Okay.
And go back to the green arrow, and then look. You have several windows that you will see then. And select the one that only shows the first slide. Do not have the PowerPoint program around it. So it's just the first slide. Do you see a slide like that?
Yes.
And then click on that one and share that one. So it should be a different one than the one you just shared. Okay?
Okay.
All right, and then let's see if you can move it forward. Otherwise, out of time's sake, then I'd say let's just leave your first slide and you talk over it, and we'll the audience can just follow you as you're talking. Want to do that?
Okay. Yeah, still not moving. I'm sorry. What did you say again?
And you can just go into your PowerPoint program and talk over the PowerPoint that you're seeing there, and then the audience can just follow you. It's fine.
Okay. I know that's not ideal, but thank you so much for your patience, and I apologize for the technical difficulties.
No problem.
Okay, and I'll move quickly. So as you can tell, the title of my slide is In Presentations of Virtual Vernacular of Health, Understanding How Black Women Interpret Obesity and Weight Loss Messages. So the problem, as I see it, is Black women face the highest rate of obesity in the U.S. They face approximately 63% of obesity. Black women also use mediated health communication to replace information from doctors. So if they don't have enough money, or maybe may not have the time, or if they have mistrust of doctors because of past historical maltreatment, they may use the information they get off the news or the internet to help them make decisions about their health. Additionally, 73% of Black Americans use the internet. So they're using TV for health communication and the internet for their social interactions. Well, the problem in the public relations literature is when it comes to creating messages for a Black female audience, they do a lot of surveys, and when it comes to asking about race, they may look at it as an objective question to ask at the end of the survey without looking at the nuances of race and how that may affect someone's communication. And just to give you definition of terms, when I say public relations, this particular industry looks at communication and how to manage that communication between an organization and its publics. Publics meaning a group of people that face similar problems about a particular issue. And in this context, I'm talking about the issue of obesity, how Black women face and communicate about the issue of obesity. And as I said earlier, public relations and also other communication fields look at race as a static variable, something just to mark at the end of the survey they may distribute without realizing how does race affect someone's communication. And so this is what this particular study aimed to do, take an audience-centered approach to see how Black women understand the issue of obesity and how do they share that on the social media platform. So a little more about the theoretical framework of situational theory of publics. It has three variables: problem recognition. Do the audience see this issue as a problem? Level of involvement. Is this audience involved in the problem? And constraint recognition. Are there any constraints for this audience to perform what's being asked of them in the communication message? So based upon problem recognition, level of involvement, and constraint recognition, will the audience process the information, which is passively looking at the information, or will they seek out more information about what's being talked about? And like I said, a lot of times public relation scholars and communication scholars really don't take a nuanced look at race and how it affects other issues. And so in my particular study, I incorporated what is called the multidimensional inventory of Black identity. This is usually based in psychology literature, and it looks at how Blacks, what being Black means to their self-concept. So how does being Black affect another issue in my life? So with this particular study, I want to look at how, as Black women, does their race affect how they communicate about obesity and weight loss communication messages. And so what I did was I took an audience-centered approach so we could get feedback from the women, because surveys merely just tell us what, but when you do a focus group, it tells us the why behind the numbers and the information you get off of surveys. So we did a focus group, 21 women, Black females, in Oklahoma. Oklahoma is the 7th fattest state in the U.S., and we incorporated not only information about the situational theory of publics, but we also incorporate information from the MIBI, the Multidimensional Inventory of Black Identity, to see, again, how, being a Black woman, how do you interpret weight loss and obesity messages? So this was a part of a larger study for my dissertation, but I'll just give you a few of the findings. First of all, we found out that Black women do not consider themselves obese. Black women do not use the word obesity. But if you look at a lot of health communication campaigns, a lot of them use the word obesity, anti-obesity campaign, or here's some solutions so you will not be obese. So going back to the situation theory of publics, one of the variables is problem recognition. These women do not recognize obesity as a problem because they do not use the word obesity in their regular vernacular. Another thing they talked about was, as a Black woman, they love their curves. So when they have these messages about skinny women, showing pictures of skinny women, that does not involve them in the message either. So overall, Black women that participated in my study would like to see realistic words that they use, and they use words like they want to be healthy, and they say, they use the words overweight. I'm overweight, but I want to be healthy. So those words need to be incorporated in health communication campaigns. Also, the women talked about the unrealistic prices of the solutions to lose weight, and also the unrealistic images. So the women would like health communication campaign creators and scholars to use words that are relative to them. They would like to use images that are relative and closer to their body image, and they also want to see more realistic messages for them. And because they use the internet, another finding was most of them use the internet to look for health information. So moving forward, instead of just traditional television, they would like to see messages on social media sites that they use on a regular basis. That includes Facebook, that includes Twitter, because again, 73% of Black Americans use social media sites. So it would look something like, maybe have an encouraging word, or have a campaign where they mention participants' names who have lost weight on the weight loss journey. And so when they incorporate these more realistic elements in health communication campaigns, I believe that Black women will not only be involved in the message, but it will remove constraints and help them to move forward, to live a healthier life, and to lose weight. Thank you for your time.
Thank you so much, Christal. We enjoyed your presentation. Finally, you made it. And our last presenter is Ernest Martin at VCU, and he's going to present a study titled From Confusion to Clarity, toward better measurement of discrete emotions evoked by media health messages. Ernie, are you there?
Yes, 1 second. Let me share. Do you see it?
Yes.
Has it gone to the second?
Not yet.
It has not gone to the second.
Mute.
Okay, if it hasn't gone to the second, let me stop. Still cannot see it.
No, right now it's not sharing at all.
Okay. Let me redo. I apologize.
No problem.
Share screen. Entire screen. No. Wow. There we go. Still not.
No, it's not sharing.
Still not sharing, right?
Hold on.
Give it a second. Oh, that's still not coming through.
Yeah, it was just we saw you going to the second one, so it.
Is it coming through?
We go to the second.
At this point, can you see it?
Yes, you're good to go.
Okay. Sorry about that. The study, as was said, is from confusion to clarity, which may be clear in about 1 minute. This is a presentation that's designed to improve our ability to pretest health communication messages, especially when we're measuring emotion or affect. Research into media processes and effects is a study of how human beings interact with mediated messages. And research methodologies, as we've seen today, vary to include content analysis, surveys, focus groups, experiments, and many other things. And one of the experimental processes use measures that are called psychophysiological measures that enable us to observe embodied mental processes that are engaged during media consumption. I think it'll be clear in about 1 second. Now, look at this picture. The strength of psychophysiology lies in its ability to capture responses that are covert. How do you feel when you see this? Well, you probably can't describe it, right? So even when participants are unable or unwilling to express their thoughts and feelings overtly, psychophysiological measures capture some of the key psychological states such as level of attention, emotion, and arousal that serve as key indicators of what is going on in their mind. Heart rate is one of the measures we use, and it is used to measure attention to media messages. Skin conductance, on the right-hand side of the screen, is a measure of electrodermal activity representing arousal to media messages. But what I want to focus on is electromyography, or facial EMG. We use this to on facial muscle groups to measure emotional direction. And the typical configuration of sensors in measuring emotional processing of media contents is as shown, which shows us pleasantness or unpleasantness. Now, we need to go beyond pleasantness and unpleasantness to distinctly identify the occurrence of discrete affective feelings. Ultimately, a significant part of our emotional experience that's evoked by media includes the presence of affective feeling states, things that make us angry or afraid, sad, disgusted, surprised, or happy. And we need to measure that. Now, however, facial EMG of these discrete affective states need to be measured, but they've been less reliable than the current protocol of measuring pleasant and unpleasant. So, purpose of this study is to address underlying reasons for lower reliability of discrete measurement and points to future modifications in protocol which may lead to more reliable measures. Now, it was a three-phase research study or method, which I will describe as I go through each phase. In phase one, it was to determine recognition and confusion of the 6 basic emotions plus neutral. Our initial method was an online survey. Sample size was 583. Participants were undergraduate students enrolled in online introductory mass communication courses. Participants judged which of 7 facial expressions, neutral, happy, angry, sad, fearful, and disgusted, were displayed by a set of 42 faces selected from a database tested database of faces. 2 female and 2 male models were randomly selected from the photo database, and all 4 were shown in straight angle, and 1 male and 1 female were additionally shown with all emotions in half left or half right. At the bottom is one of the people with the different facial recognition. So they did that measure. Across 42 photos for the total participants, the correct identification of emotion was 8 out of 10 correct, 79.2%. Our critical question was, which emotions are most easily confused? The answer to this question, to answer it, we constructed this confusion table. The leftmost column is the response, perception. The diagonal elements are the recognition rates, and the columns correspond to the error rates. I'll talk more about these results when we put everything together. In phase 2, we coded the facial muscle groups that correlated with the correct and incorrect facial emotional recognition. We used what's called the facial action coding system, which is a comprehensive and most widely used method of objectively describing facial activity. Micro movements of the facial muscles occur when certain feelings are evoked. These muscle movements are called action units or AUSs. When we coded by these 6 basic emotions, there were only 12 action units used. This slide shows that the underlying muscle structure that relates to some of the codes. We constructed a chart to show the AUs for phase 1, correct and confused identification of emotion. Now, phase 3 was to put it together. Phase 3 was to compare correct and confused facial muscle codes with current facial EMG sensor placement protocol for measuring discrete emotions. So that would give us our final results, suggesting alternatives to test for greater reliability. Now, fairly quickly in the emotions for happiness, there were very few confusing it, and the protocol actually should be, according to this coding, reliable as well. For surprise, it used 4 action units which were all shared with other emotions. The total combination led to minimal confusion with 6%, but if we add AUs 2 and 26, it may be quite similar or more reliable. Anger, with 21% confusion, we have the potential to perhaps increase this because anger in our current protocol uses 4, 5, and 7. One of those is shared. But part of the sharing is might be a confusion with sadness and disgust that we found in phase 1. So by adding AU15, adding a fourth sensor, we may be able to control for sadness and disgust and increase the reliability for measurement of anger. In sadness, sadness uses 3 shared AUs, and confusion arises with fear and disgust. Here again, current protocol calls for 3 different sensor placements, but perhaps adding AU10 will check against disgust, which may increase our reliability some as we test this. We get to disgust. Disgust also uses 3 AUs in current protocol. One of those is shared. Current protocol only uses 9 and 15, where in facial action coding there's 3, 9, 10, and 15. Perhaps adding the 10th to electrode placement will increase the reliability. The last one, fear, is most difficult and most complex. It has 6 AUs in the coding, facial coding, and 4 of confused emotion share a total of 8 AUs. About the only thing I can say on that is more testing if necessary, but potentially we could add 2 more sensor setups to perhaps increase it. So, as I'm running out of time, in health communication, we're looking for results that give us directions as to better insights in how we put forward our messages. These tests may modify how we do our emotional tests to provide better insights for the health communication messages. Thank you.
Thank you so much to all for your insightful presentations today. Now we'll have a discussion time with our discussant, Dr. Yan Jin at the University of Georgia. Dr. Yan, are you ready?
Yes.
Yes, please start the discussion section.
Okay, great. Well, I want to thank all the presenters today because you all delivered a really cutting edge and interesting and very insightful discussion based upon your research. So for my comments here, I will start with like the common theme as I see that your research has kind of put together elegantly, and then I'll give some more specific comments to individual study. It's not really a like critique, but it's more like open up more discussion moving forward together. Okay, so interestingly, Ernie, to piggyback upon what you just said, in health communication, we need better insights with more effective messaging, and also with better measurement, with increased precision and clarity. Okay, so interestingly, all the 4 studies touch based upon the core of emotions. So, for example, in Marta, in your study, you focused on the vaccination issue, right? So, the central emotion that your study was focusing on is like fear, right? It's fear from the parents about the side effects of vaccination, and that fear itself sometimes can really kind of increase the anxiety or confusion. So when you are confronting a more powerful, more emotional driven messaging from anti-vaccine group, that can overpowering, even though probably you should trust government agency or health organization. But what if that type of fear can prevent probably more accurate information getting across the board? Okay, so I think that's really, really interesting. And then for for Rowena, in your presentation, right, for younger generation, the issue of STD, it is a issue that embedded with the feeling of embarrassment and shame, right? Even though we talk about for younger generation, they like to share, like the peer opinion leadership seems to work better. However, when the issue is so sensitive, even if they can talk about it in a private setting, if people ask their opinion, however, there's a hesitancy to share, to talk about it, just because the issue is so sensitive, right? So in that case, we're talking to or have dialogue with younger generation who is naturally like to share. However, the issue sensitivity makes them less likely to share something might be perceived as embarrassing or shameful. So that's another kind of challenge that we're all facing as health communicators. And then let's move to the theme as related to Christal, your study. And interestingly, you mentioned about the message about obesity and weight loss, among Black women could be unrealistic and also confusing, right? So that sense of confusion can be a strong barrier for health message clarity and effectiveness. So, and then moving from their individual discrete emotions, in Ernest's study, really kind of argue for that, yes, we do need to resolve those confusion in our message, and then leading towards clarity. So that's kind of a quick summary of the themes as I detect based upon the wonderful presentation you gave us. So now let me move quickly to give some comments or thoughts for each individual presentation. Okay, so back to Marta, I really enjoyed listening to your presentation, and really great job in content analysis. The method, the approach was really, really good. So here, I think it would be really interesting if in your publishing, writing your data, if you can have some coding item to detect the emotions and also the sentiment that embedded in the message. That'll be actually really interesting to see if there's any fear, confusion, or anxiety in those comments or responses. And then another framework you might consider, is because the nature of vaccination, it's really a great opportunity for you to look at the two parties from a conflict management, conflict communication perspective, right? The pro-vaccine, anti-vaccine. So consider maybe you can apply the conflict framework to see how the two parties has been using different conflict strategy to argue for their points and how effective it is, as evidenced in those coding results. And lastly, I wonder whether you have coded, or maybe in the future, for your future thoughts, when the parents, they were sharing, discussing vaccination information, in the responses, are there any more like official, let's say, health organization? Is there any responses coming from a health authority? So you've been observing, monitoring this discussion, right? Is there any interventional approach, at least to respond, to correct inaccurate information or argument? It's just kind of a quick thought, but I think that'd be really interesting from, again, from a conflict management or from health intervention perspective. So really great study, and I'd love to see the article published in some really good journal. Thank you. And so for Rowena, again, fascinating research, really timely and important. Very compelling when you pointed out the gap between, look at how the internet or social media penetration among younger adults. However, their actual usage of internet and health apps, for example, to actually actively seeking information about health is relatively low. So this is a really bigger research question, right? As health communicators, how can we address that gap? Okay, what kind of factors contribute to this gap? In one of your slides, you mentioned about the theoretical framework. Probably in a journal publication or manuscript, the reviewers might be more might ask you to clarify what are the theoretical framework behind the paper. I know this is like a report, like subject to CDC. Maybe the audience is more practitioner-oriented. So think about a scholarly journal. You might want to think about what kind of theoretical framework you would like to incorporate in the manuscript. Okay. And again, as I mentioned earlier, so a more general implication, how can we approach a sensitive health topic? At the same time, encourage them to not just seek information, but share information, how to motivate younger generation to create a healthier discussion about those topics. But again, I really enjoy your presentation, and I'm looking forward to seeing that out in publication. And Christal, your study touched base a really, really important area, about racially tailored message. And then one of your study reminds me of another kind of related health literature. We keep hearing research about culturally appropriate or culturally racially tailored. However, the racially tailored or culturally being culturally appropriate is a concept or construct. It's never really clearly operationalized or defined. Okay, how do we know the message is racially tailored? How do we know the tailoring is culturally appropriate? So I think those are really kind of bigger but very important questions that your paper actually really shed light on as a great example. So I have some more specific thought here. In one of the slides, when you listed the purpose of your research, right? Really happy to see you utilizing PR theory framework there. You listed racial identity, and then involvement in the issues, in this case, obesity and weight loss. And then you listed information-seeking methods. The way you structure the three major frameworks, sort of kind of like parallel at the same level, right? So I wonder whether there's any kind of hierarchical association among those three areas. For example, would the racial identity together with involvement of issues predict information-seeking methods, or in a different way they are connected? So I think that further elaboration of how those three major frameworks or concepts are intertwined with each other, predicting certain outcome, that would help clarify the framework part even better. And lastly, for Christal, in the discussion part, it would be really, really interesting in the journal article, because you mentioned very insightfully that the target audiences desires racially relevant weight loss messages that reflect participants' experience, lifestyles, and barriers. So if you could articulate what are they? So if this is not working so far, what kind of messaging, as a model yet to be tested, for example, but how they look like, what kind of factors, what kind of information will lower the barriers, will work better? I think that would be really helpful in the practical implication session of your paper. Okay, and lastly, Ernie, I just really admire those work and really pushing the measurement landscape in health communication research even further. This is much needed area, and I hope there will be not just conceptual paper, but also empirical study and testing. There's more enhanced measurement combined with self-report measures into publications and discussions, applying those measurement and advancement to understanding different health messages and different primary emotions that might be embedded naturally in different health conditions. So those are my comments and thoughts, reflections really, to the four wonderful presenters and your really, truly great work. It's my pleasure to share my thoughts with you. Thank you.
Thank you so much for your meaningful feedback. And now we'll have some time for questions from audience room. My colleagues Scott Sherman and Osita Irebu are standing by in our audience room. So, and also they can check the Twitter. So if you have any questions, please ask, or you can post on Twitter with the hashtag VCU Global Health, and the presenters can answer your questions. And Scott and Osita, do we have any questions?
Yes, we do. From Twitter, we get a question for Marta. What specific roles can online opinion leaders play in the formation of attitudes about vaccines?
Okay, can you hear me? Okay. Okay. I also quickly replied to your tweet on Twitter. basically, I can just mention what I mentioned in the presentation, that their specific role is enhanced both by the types of message that they write, so the arguments, the sources they use, the information that they provide, the vaccinations that they talk about, but also in the specific, their role is enhanced by the social network environment, which has some kind of a network impact that, let's say, amplifies all messages. So the thing is that we measured for each user the position, the opinion, the attitude towards the vaccination at the beginning of the thread, and then we measure it again at the end of the thread to see whether this attitude has changed. And then we have a look at what is inside, so what's going on between position 1, between attitude 1 and attitude 2, and then we can see whether they actually have come across any information by these opinion leaders during this conversation, during this discussion, and then we can attribute the change in the attitude to the fact that they spoke to opinion leaders.
Thank you so much, Marta. And because we kind of limit, we have to limit that. And please continue the discussion using the Twitter with hashtag VCU Global Health, and you can ask questions to the presenters, and they can answer your questions. And we'll now have a short break to set up everything for next section. And the next session will start at around 4 p.m. And the live stream will again available on our website, Media Plus Health Symposium website. So please stay with us. Thank you so much.